Hello, I'm David Hyams, a surgical oncologist in Southern California, and I have an opportunity to speak with you about Oncotype DX for colon cancer. It's been 10 years since Genomic Health first presented the Oncotype DX for breast cancer, which has provided useful information for thousands of women with this disease. Oncotype DX for colon has now been available for 4 years and provides also very useful information for patients with stage 2 disease. This assay, which is designed for stage 2 disease, really focuses on individuals who have mismatch repair proficient tumors. Those individuals with mismatch repair deficient tumors have uniquely good prognosis and are not likely to be candidates for additional cytotoxic adjuvant therapy. In looking at the patients who are mismatch repair proficient, we'd like to focus on those individuals who have T3 tumors and those individuals who have T4 tumors, as each have slightly different issues to be considered. So let's take a look at the report that Oncotype DX colon provides you. Oncotype DX for colon cancer uses RT-PCR technology to determine the expression of 12 genes in tumor tissue that's provided from each clinical site. So looking at the example report that we have in front of us, we can see a recurrence score of 48, presented in bold letters at the top. If we look below that, we see two numbers, a recurrence likelihood based on a patient who has T4 disease, and a second result based on patients who have T3 disease. In the first case, the risk of recurrence is 34% based on this unique score, and in the second case, 20% based on this unique score. This can be useful for making decisions. You will note, however, that there is no subdivision into low or intermediate and high-risk categories, because we want to stress again that this is a continuous score that has a unique implication for every patient. There is a shaded area that can be seen in the curve to the right, which indicates an area of relatively high risk for those patients who have T3 disease. And this approximately correlates to a risk that's at least as high to those patients who have any score but have T4 disease. We know that T4 is a particular risk factor, and many medical oncologists will recommend chemotherapy to any patient who is able to receive it with T4 disease. But I think that this presentation is uniquely valuable for two reasons. One, it shows us the patients with T3 disease whose risk is elevated and in whom adjuvant therapy may be of value. But it also shows us those patients with T4 disease who, because of other competing features, we may wish to try to avoid using chemotherapy unless their risk is truly high. As an example, a patient with a score that may be in the range of 10 might have a risk that's sufficiently low even with T4 disease that with competing risk factors such as heart disease, diabetes, etc., we might wish to avoid cytotoxic chemotherapy. On the other hand, we can see patients who have T3 disease and see those individuals where clearly their risk is at least that of a T4 patient, but for an otherwise healthy younger individual with a strong motivation to reduce the risk by any degree possible, even a slightly lower score might be utilized. This allows true individualization and personalization of care. If we look at the second page of the report, we see data that has been derived from the NSABP C07 clinical trial. This study looked at 264 patients from that trial in whom tissue blocks were available for evaluation. 247, or 94%, were patients with T3 disease. And we can see a calculated percentage of recurrence risk at 5 years following adjuvant chemotherapy. The first number presented are those individuals who would receive 5-FU leucovorin alone, and the second score presented are those individuals who have oxaliplatin added to their base of 5-FU leucovorin. In each case, we can see the approximately 20% reduction in risk that we get with chemotherapy across all recurrence scores. This now provides information that allows a physician, clinician, to sit down with their patient and assess competing risk, patient desire, and the appropriate toxicities and benefits that are likely to be obtained with any therapeutic intervention. So I hope that this information was useful for you. However, if there are additional questions or any other information that's required, your genomic health representative would be happy to help you.